Hello, everybody, and thank you for joining this webinar. My name is John McKinley, and I will be your host. Today, we're privileged to have Dr. Amin present on the combination of surgery with HIPEC and Electron IORT for the treatment of abdominal and pelvic sarcomas. At the end of this presentation, we will have a Q&A session. Please submit your questions in the box at the bottom of the screen. Dr. Amin is a senior distinguished consultant in surgical oncology at King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. He studied medicine at Manchester University Medical School and trained in the UK, Canada, and the USA. With a career spanning more than 40 years, Dr. Amin is one of the first Saudi surgeons to provide specialized surgical oncology services in Saudi Arabia. He has established numerous cutting-edge surgical programs, enabling complex procedures to be conducted in Saudi Arabia instead of being referred abroad. He has pioneered the introduction of cytoreductive surgery and hyperthermic intraperitoneal chemotherapy in Saudi Arabia. Dr. Amin has also established a sophisticated intraoperative radiotherapy program for advanced cancer surgery in Saudi Arabia. He has also applied the combination of HIPEC and IORT in selected patients with advanced cancer, and he has the largest number of patients treated with this combination in the world. Now, I'd like to hand it over to you, Dr. Amin.
Thank you very much. Appreciate being invited.
In this presentation, I am going to present my own personal experience with the use of surgery plus hyperthermic intraperitoneal chemotherapy, HIPEC, and intraoperative radiation therapy, IORT, in the treatment of abdominal pelvic sarcomas as a novel approach. I like to state that I have no conflict of interest, and this presentation is entirely educational and for exchange of experience and ideas. And also, I would like to give my appreciation to the IORT team at the King Faisal Specialist Hospital, as it is a team effort. It is generally accepted that the results in soft tissue sarcoma treatment is really dependent on the histotype of the sarcoma, and the histological subtype plays a large part in the recurrence rate and in the overall survival. It is to a lesser extent by the size of the tumor. And in some tumors, the issue of resection margin is an issue, and this is influenced by anatomical constraint and histological subtype. There have been several nomograms and predictive tools made for soft tissue tumors, but they have not been successful so far to direct the treatment as indicated in this review. As well, there are variable treatment. The diseases are rare and many subtypes, almost over 100. No treatment standards, and there's newer modalities are available and used in variable combination. Looking at this article about the Netherlands cancer registry and soft tissue sarcoma, it is indicator of the present overall treatment landscape in sarcomas. And we can see here that chemotherapy is only used in about 5.9%, and it's been decreasing over the years, reflecting that the current regimens or agents are ineffective. And we still hope for more effective agents in the future. Again, it shows that the radiotherapy is used in about 50% of patients, with increasing preoperative use and decreasing postoperative use. In our experience, the KFSH, the use of radiation therapy is less than that documented, mainly related to the large size, anatomical constraints, and because several are recurrent disease. This is also reflected in the ASTRO recommendation, which has just been published, in that radiotherapy in general is not recommended, and if it is going to be used, that the pre-op use is better than the postoperative use, and that the pre-op use should be considered in specialized situations, not for all patients. Again, in this slide, again, the recommendation is again to avoid postoperative radiotherapy and use only in highly selected patients. This is reflected by the NCCN guidelines, in which the final recommendation is surgery to obtain negative margin if possible, plus or minus intraoperative radiation therapy. In this review of intraoperative therapy for soft tissue sarcomas, it emphasized the role of IORT as a boost and when combined with external beam radiation therapy. But this is mainly for limb sarcomas, not for the retroperitoneal sarcomas, which uses much less than the limb and trunk sarcomas. And that combining IRT with surgery is superior to surgery alone. And the emphasis is in avoiding normal tissue injury. And in this table, in which it looked at retroperitoneal sarcoma, we can see that the number of cases is small, and they vary between 13 to 87 patients in the number of series. In our series, it's about 55 patients, so we're well within the numbers stated in these tables. But it's important also to note that the local control rate varies from 20 to 83%, and this is reflecting the practice and the referral pattern of the institution reporting the data. In my experience for IORT, since we established a program in 2013, I have used it in 332 applications in 280 patients. And you can perform multiple applications at the same setting in some patients, that is in about 32 patients. And this was mainly overlapping fields or a field within a field. IRT can also be repeated in subsequent surgeries, usually due to different location of the recurrence of the tumor, as you can see in this table. But the problem is there is still a significant local failure rate, either local or peritoneal. The lymph node metastases play a small part in this kind of tumor, period. So, and you can see in this slide, there are some of these cases that I've operated upon. There are here are sarcomatosis, and that surgery and IRT might not be sufficient to prevent recurrence or deal with the patient. It's also in a very large aggressive tumor that crosses barriers or cross regions, and occasionally we have to do piecemeal resection to remove the tumor with the significant cancer cell spillage, or due to large tumor which have a close or insufficient resection margin to be removed, where the risk of recurrence is extremely high and the peritoneal metastases or multiple sites of recurrences are possible. One solution to the problem is to use HIPEC to prevent either peritoneal SPED or to treat peritoneal SPED that is present at the time of the surgery. I mentioned is HIPEC, which is cytoreductive surgery and hyperthermic intraperitoneal chemotherapy, in which we resect the tumor to leave no visual tumor if possible. Then introducing a perfusion system through catheters, which are heated to a temperature between 40 and 42 degrees Celsius, to avoid temperature of over 43, as this is toxic to normal tissue. But 40 to 42 is selectively toxic to cancer cells. And it also increases the killing of cancer cells by the chemotherapeutic agents and increase the penetration of the chemotherapeutic agents into the tumor nodules that are left or into the positive margin that is left. And we inject the chemotherapeutic agent once the temperature is maintained in the abdominal cavity at 40-42. You can see in this slide that sarcoma is one of the worst diseases in terms of results, as it's classified in others. due mainly to the resistance of this tumor to chemotherapeutic agent, and also to the variable chemotherapeutic regimen used, which some of them are ineffective against the sarcomas, and also due to the lack of experience. As you can see in the table next to it, that in one disease treated by different centers, you can get a wide range of mortalities, which can affect the results. And also that there is a steep learning curve for HIPEC in that it requires 140 procedures to acquire expertise. And you can see in one recent study, most of the centers had very little experience, and this can dramatically affect the results. My regimen for all the cancers is you have to have multiple regimens because you have to meet different situations with chemotherapy in patients. But for sarcomas, basically use either melphalan, cisplatin, and doxorubicin, or gemcitabine and docetaxel, all intraperitoneal. But increasingly, I've been using the bidirectional approach in which we give intravenous ifosfamide and mesna, as well as intraperitoneal cisplatin and doxorubicin. This followed the major study done by Dr. Sugar Baker and his colleagues in the use of bidirectional ifosfamide in a number of patients, and they showed that it has a good safety profile and with excellent results. But all of these patients were non-sarcoma patients, and therefore we adopted this study with the Sugar Baker regimen, and we used it in a large number of sarcoma patients. But we used the real life, and some of our patients were elderly and they had a lot of comorbidities, but mostly sarcoma patients. And we did have some element of renal impairment because of the age, and because in some of the sarcoma patients we do an additional unilateral nephrectomy. So therefore, we adjusted the regimen in these patients with excellent result, as in the Sugar Baker paper. We also published an abstract showing a very low recurrence rate in 24 patients who were treated at our institution, and 2/3 of them had cytoreductive surgery, HIPEC and IORT, in that 4 out of 24 at the short term developed local recurrence. Dr. Sugar Baker then published further 3 papers, and the top one was mainly on sarcomatosis, which showed that you can get a possible long-term survival with using this regimen in the sarcoma patient, which was not possible with the previous regimens that we employed. This is a paper from the sarcoma group, which is multinational, from the Italian, Spanish, French, and Polish group. And its importance is used in these kind of sarcomas that we actually, our analysis is similar to that. And basically to demonstrate whether using a histotype specific chemotherapeutic agent or the standard adriamycin ifosfamide, which is similar to the bidirectional chemotherapeutic regimen, would make a difference. And they have found that for all the high-risk sarcoma patients, you can usually use a standard regimen of adriamycin ifosfamide with equal success, and it's not necessary to use a histotype specific. This is an indirect support for the bidirectional approach. But the number of HIPECs I have personally performed since 2008, when we started the program, is well over 571 cases. There's a variety of diseases, but you can see that the sarcoma cases is about 10.5% of my practice. Then we come to the other option. If you don't want to use HIPEC and an IORT, can you use a different combination? For example, using hyperthermia combined preoperatively with the chemotherapy, and combined with the radiation therapy. As theoretically, this is attractive, and there is a lot of evidence for this approach. Period. Then This paper was published, which is a phase 3 trial, was showing that the use of neoadjuvant chemotherapy plus regional hyperthermia is effective, and it has a significant improvement in terms of survival and local recurrence rate. As you can see in the graph, this is applicable for both extremity and non-extremity sarcomas. But despite the benefit shown, it is not widely used. The next paper looks at the use of hyperthermia in radiation therapy. It's from the University of Amsterdam. And you can see that the use of hyperthermia with radiation therapy can beneficially affect the problem with radiation therapy, especially relating to hypoxia, which is a major factor decreasing the efficacy of radiation therapy. And in the meta-analysis in this slide, it shows that the benefit, and again, that the radiation plus hyperthermia gives better results than radiation alone. And again, even though it has been proven, it is still not widely used. But the problem, as both the chemotherapy and the hyperthermia, this is mainly used for limb of trump sarcomas, but it is not applicable to all cases of abdominal pelvic sarcoma. So it limits the use of these modalities. And also there is a logistic issue, which is a factor in the application of these techniques. When we looked at the combination of HIPEC, IORT, and surgery together, we were looking at starting this combination, but this was first published by Professor Hinge from Amsterdam, where he reported on 5 cases of rectal cancer treated with the combined modality of surgery, cytoreductive surgery with HIPEC and IORT. They have not carried on using any more patients, and this, I understand, is for logistic reasons. We published later on also this use in pancreatic cancer, as we were quite impressed with the results in that disease. And in fact, number of my experience is the number of IRT procedure is total is 296. No HIPEC was used with the IRT in 86. But the combination of HIPEC and IRT with surgery is in 210 patients. 185 was with the intraperitoneal chemotherapy and 25 with the bidirectional or with intraperitoneal intravenous chemotherapy. The sarcoma patients, since we started the program 2013 to earlier this year, we had 27 HIPEC alone, and this was mainly because some of them were before the IRT was introduced, and also mainly because most of the tumor were totally resectable with an adequate margin and did not need IRT. The 55 patients were treated with this combined treatment, and this is mainly because the IRT was required because of close or incomplete margin, and we added HIPEC to increase the efficacy of the treatment. And you can see some of the examples in my cases where this is a large tumor with involving the retroperitoneal, but with coexistent sarcomatosis. And again, here other tumors that has multiple nodules that going into the soft tissue, which means difficult removal, and we can leave residual disease, or very large tumor where getting an adequate resection margin due to anatomical constraint is difficult. Again, other tumors that has been operated on, which is common in my practice somewhere else, they come in with contamination of abdominal pelvic cavity and tumor spillage. And therefore, we do wide surgery and then give the patient IRT. Then we do HIPEC and then reconstruction and closure. Other example is this patient with Ewing sarcoma who was treated solely with chemotherapy, is not regarded as surgical by other surgeons, and after he had maximum chemotherapy, he was referred in October 2012, where we operated on him and used only HIPEC in this situation, as the IRT program was not started. Then he came back with a recurrence in 2014, where we performed HIPEC and IORT. Subsequently, he came back with a recurrence in December 2015, involving the vessels at the pelvic sidewall on the right. And then we decided to also use HIPEC and IRT on him. And since then, the patient has been tumor-free and is considered cured. And I've just seen him 2 weeks ago, and he's doing extremely well with no evidence of recurrence. Another patient, young, similar to the previous patient in his late teens, who had an epithelioid fibrosarcoma, an aggressive tumor. He was given chemotherapy, but the tumor grew on the chemotherapy that we necessitated then took him to the operating room in April 20, resected that with a HIPEC. He had again peritoneal recurrence. Then we resected that again with HIPEC in September 20. And then all of a sudden he had a recurrence, as you can see, involving the retroperitoneal, causing pressure on the ureter in September 21, and he's scheduled for HIPEC and IRT shortly. This is another patient which explains the value of this technique in radio-resistant tumors. And this is the classical example is a chondrosarcoma. I'm going to present two cases where this patient has multiple chondromas which can go malignant, and one of them in the abdominal inguinal region has gone malignant. And we resected this patient in April 2018. And after resection, we gave the patient intraoperative radiation therapy and HIPEC. And so far, the patient has no evidence of recurrence and is doing extremely well. This is another young patient who came in with anuria and renal failure due to a very large chondrosarcoma causing pressure on the ureters. He was put on no code because nothing could be offered for him. I took the patient, we put bilateral nephrostomy tube for 3 weeks, improved his renal function. Then we did piecemeal resection of this tumor with HIPEC and IRT. The tumor was arising from the pubic bone, and so far it has not recurred again from the pubic bone, even though he had several 2 episodes further of peritoneal recurrences from the chondrosarcoma and also in the pelvis, which necessitated further surgery and HIPEC and IRT, and eventually to do complete pelvic exenteration. And so far, he has no evidence of intrapelvic disease except for this tumor low down in the pelvis by the ischial tuberosity, which we treated with stereotactic radiation and alcohol injection. We're still following this patient to see whether he will respond to this treatment or go back again for further surgery. But the patient is active and he has 3 children and leading a normal life. Now, in my series, we looked at, when I refer to the term mortality, it is all events leading to the death of the patient from the surgery, including in hospital and afterwards in follow-up, or patients who are lost to follow-up. In hospital deaths, it only occurred in 1 patient who died from pulmonary embolus on the 7th day. All patients left the hospital. Patients with the following diagnoses are excluded: uterine sarcoma, gynecological carcinosarcoma, solitary fibrous and desmoid, and GIST, because they have a different life history and they have better results than the usual sarcomas that we see in the abdominal pelvis. And therefore, I've excluded them because they will skew the results to a more favorable statistical analysis. And you can see in this slide there are 43 patients, of which 32 had HIPEC and IRT, and 11 patients have had HIPEC. And you can see that One third of the patients with HIPEC died, while 1/5 of the patient with HIPEC and IORT died. In the next slide, you can see that the survival at 40 months for HIPEC alone is 50%, while the survival for HIPEC and IORT is significantly better, 79%. I know this is a small number of cases, and the statistical analysis might not be that accurate, but this is the figures we have, and I'm no different than many of the other series because the numbers are equivalent. But from a clinical point of view, it coincides with what we observe with the patients. The next slide shows the survival analysis by the completeness of cytoreduction. And you can see that in the patients who have had no disease or very microscopic disease, there were 36 patients, of which about a quarter died, and one who had gross disease, which we consider palliative because we left gross disease. There were 7 patients, 2 died, which is also again about a quarter of them. And you can see that the survival at 40 months for both is not much different, slightly better for the complete cytoreduction than the gross disease, at 74% and 62% respectively. And finally, the last slide shows the overall survival. This we have not reached the median, but it's calculated 5-year survival is 65%, median follow-up of almost 24 months. And we can see even if we put the lower confidence for the median survival, which we calculated, survival is still at 45%, which is a very good result for these difficult patients. Therefore, my final recommendation is that the major treatment is surgery and IORT. If the patient has incomplete or close margin, and adding HIPEC to the regimen will improve the results for these patients and prevent locoregional and peritoneal recurrence in a significant number of patients, and will increase the overall survival, as local recurrence is responsible for 75% or 70% of the deaths of the patients. Thank you.
Thank you very much for that very informative presentation, Dr. Amin. We will now begin our Q&A session. Please submit your questions with the Q&A box. I see some questions coming in now. What other factors play a role in IORT outcomes?
For us at the moment with IORT, we are mainly basing the dose of IORT on whether it's clear margin, microscopically involved, or grossly involved. But I think we also have to take account into the biological activity of the tumor, the histological subtype, in using the dose. But unfortunately, also organs at risk, particularly nerves, might limit the amount of IORT dose that we give. And therefore, I think that's why adding hyperthermia, plus or minus the chemotherapy, might help us in this way to overcome these issues, to increase the effectiveness of the IORT.
Thank you. Another question. What is the optimal HIPEC technique and regimen for sarcomas?
This is a difficult question because, unfortunately, many of the articles published in the past have used inappropriate chemotherapy, for example, mitomycin C or oxaliplatin, etc. These are not tumors that are effective against sarcoma. We know that the sarcoma is basically has very few drugs that are effective to it, and very few of these drugs can be used intraperitoneally with HIPEC during surgery. And the two classical drugs that can be used is ifosfamide and adriamycin or doxorubicin. Doxorubicin is an excellent drug, but we cannot use it at a high dose in the intraperitoneally because we can only use a maximum of 15 milligram per meter square. Otherwise, we introduce fibrosis. Ifosfamide, which is a very interesting drug, it is a drug that tends to be potentiated with hyperthermia to 6 times or over in terms of cancer cell killing. And that has been demonstrated both experimentally and in vivo. So that's why the bidirectional approach. So it's not a question of the IV, it's a question of drugs to which the sarcoma are sensitive. And I think like with the Italian and Polish study have shown that this standard can be used for most sarcomas. And that's why I put that paper into the introduction. Finally, the other important part is the hyperthermia. We know that from all the experimental data that you have to have the hyperthermia for at least 1 hour. If you have it less than 1 hour, it's not as effective. So therefore, it is important to have it for 1 hour plus after the treatment is given. And secondly, it should be at a temperature between 40 to 42 or 43. Otherwise, it's not effective. And that's why HIPEC, using 1 hour or plus, 60 to 90 minutes, and using a temperature that's controlled with temperature, satisfied the requirements for the effectiveness of hyperthermia to augment the radiation therapy, as well as adding the chemotherapy.
Thank you. Another question, where do you apply IORT for sarcomatosis in multiple regions?
If you can excise them, it has to be selective. If the sarcomatosis is easily resected, which is usually the most of the situation that I encounter, but if it is in an anatomical difficult area, for example, in the porta hepatis or on a near an artery, like the aorta or vena cava stuck to them, or near the bifurcation of the common iliac, like the case I presented, doing extensive vascular reconstruction is too morbid for these patients when you know that the cure rate is low and the recurrence rate is high. And therefore, IORT is useful. And I have shown you in one of my slides, I've used it. I've used 3 applications in 1 patient at the same time, very successfully with no problem.
Another question. Do you see tumor lysis syndrome and renal failure in IORT hyperthermic IP chemo patients with large RP sarcomas?
No different than any other major surgery. And I think in JAMA, there was an publication entered which showed that HIPEC has the same mortality as WIPO. What you need to do is to have a very sophisticated anesthesia team and a very sophisticated intensive care team. And we have a very sophisticated as well intraoperative monitoring technique to monitor these patients. So we do get renal failure like with any other surgery, not much more. And in fact, we've also published a paper that is widely quoted regarding the nephrotoxicity of cisplatin and doxorubicin in a significant number of patients. And we've recorded as to have the lowest rate of nephrotoxicity. So I don't think the treatment itself is a cause of the nephrotoxicity. It is also the perioperative care and management of these patients will add considerably. And the preoperative preparation of these patients, which we take a very particular attention to decrease this rate. Even if you do get renal failure, most of them are temporary and do recover. The fact, yes, we use chemotherapeutic agents that are nephrotoxic, but we also take precautions in terms of the hemodynamic and the management of these patients to try to reduce the effects.
Thank you. Another question. Is CRS, IORT, and HIPEC can be implemented in metastatic gynecological sarcomas?
Yes, very much so. I think ovarian cancer is one of the cancers that is particularly responsive to HIPEC. I've done something like almost 80, 90 cases of gynecological malignancy, and I've shown that my survival is like 10% more above what is quoted in the literature, but we haven't published that. And I'm not doing much now because I've trained my gynecological colleagues to do HIPEC, and now they have their own program to do so. But it is very effective. The issue here is, as I said, is using the appropriate chemotherapy. So you have to look at the chemotherapy that the patient has got before and to try to use a different chemotherapy that the patient can be responsive to. The idea is also to use smaller doses of multiple chemotherapeutic agents to get effectiveness, and not to use like mitomycin for everybody. This is the wrong approach for dealing. So the surgeon has got to start to acquire knowledge of chemotherapy as well, to be able to have a rational approach towards HIPEC. And the important thing as well is if you're using it with HIPEC, because you're using hyperthermia, you have to select the chemotherapeutic agent that are potentiated by hyperthermia. Not all chemotherapeutic agents are potentiated with hyperthermia. So that's also needs special knowledge of which kind of chemotherapeutic agents to use.
Thank you. Another question. What is the upper limit of PCI in patients with sarcomatosis?
Yes, that is an interesting question in the PCI. I look exactly like the NCCN guidelines, which say, is it resectable or not resectable? I think the PCI in sarcomas might not be as valuable as, say, in colorectal cancer or other tumors, because of the histological subtype plays quite an important part. And therefore, if I can see that the tumor is resectable, and there are multiple resectable with no comorbidities, not resecting major structures like aorta or etc., then yes, it's not, the number is not that important for me, as long as I can resect it and deliver HIPEC safely and get the patients through the procedure safely.
Thank you. Another question. What is the time-lapse sequencing timing between HIPEC and IORT?
Yes. Yes, that's an interesting question. We looked at that, and we have some evidence, and I'm glad that the evidence supported the approach we took. So all the patients get the surgery, that you do the resection, then you apply IORT, then you apply either do the anastomosis if you have to, and then apply HIPEC. The heat should be the last treatment, as I quoted in one of my slides, to get effectiveness of the primary treatment, which is either chemotherapy or radiation. Usually the timing experimentally was shown in the 1980s that you should not use heat more than 4 hours after giving radiation or chemotherapy. The effectiveness decreases. And this was done in, and then there was another study done in Amsterdam, which counteracted it and said maybe 90 minutes and 60 minutes. So we always go between 30 to 1 hour. We should be, after we do the IORT, we immediately set up for HIPEC within 30 to 60 minutes.
Thank you. Another question. Logistics can be a big hurdle. How do you handle this?
That's interesting, because I talked with a few colleagues who are using IORT, and some of them are not using it as much because of this issue of logistics. What we have done is to try to form a team in the IORT, which I'm really very pleased to have an excellent team to work with. And we come up with solutions on how to reduce the time, because operating room time is very expensive. And we have other treatments going on, like HIPEC and bidirectional also as well. So we have a WhatsApp team. We send a case which we want to book. The case is agreed, everybody agrees, so who knows who's going to come to the operating room. The radiation oncologists also have the number of the patient. I also phone him myself, so we can agree on that on the IRT. Remember that intraoperative radiation therapy is sometimes a surgical decision in the OR, and that is the problem for MDT meetings, is because you can change the decision in the operating room. So it's better to be prepared for IOT and cancer, which is in a very small number of cases, than find that yourself you needed IRT and you didn't give the benefit of it to the patient. It's allowing the team members to come in. So many of the ideas came in from my younger colleagues in the IRT team, and we adopted it, and we got the system going very smoothly. And I think you've got to work as a team to get optimal operating room time management. We also have the same problem with HIPEC, which we also standardized and perfected, and also with the bidirectional, because we have to have chemotherapy nurses coming in to give IV chemotherapy. So all of this comes into the OR, and it's just how you work it together, and you make a good team, and it works very smoothly.
Thank you. Another question. Does the treatment of these large tumors not ask for the use of large specialized applicators like squircles or other shapes suited to abut several fields?
Yes, some of them do, but as we say, we don't have the luxury of having so many different kinds of applicator. So what the maximum is around 10 centimeter. So we developed the technique of progressive field, where I use lead shields and then expand the field, so I can have double the field if I want to, but to give different application at the same time. So we give one field into like a semicircle, and then go on to the next field. So in effect, we can increase the area that is given, and then also at the same time use the lead shield to protect normal tissue, so we don't damage normal tissue. It's time consuming, but it can be done. But we haven't had anybody in our department develop much larger applicators for this. So we find this approach works well for us.
Thank you, Dr. Amin. I'd like to comment that Introp offers dedicated applicators, which are rectangular up to 8 centimeters by 20 centimeters. We have one last question for our webinar today, Dr. Amin. What are other measures you can use to improve resection rate and guide additional therapies?
Yes, that is an interesting question, because when you make a decision for intraoperative radiation, you're basically basing that decision on the imaging. And we notice sometimes the imaging is not always as reliable in real world. So therefore, you might take the wrong decision whether to give IRT or not. And you might set up, because you need to set up the quality assurance in the morning before you start. So therefore, we've also used the techniques of 3D printing and virtual imaging in some patients to try to get an idea of the area and the potential area that we do for IoT. And it has been extremely useful in some situations where the imaging completely failed. So I recognize there is a problem with imaging, and that's where the need is very important when you make the decision for IRT. So we also compensate by, if we think that the patient might need IRT, we set up for IRT, and better to cancel the case than not give the patient with the benefit of IRT. This is only a small number, but having virtual imaging and 3D printing, and possibly in the future, artificial intelligence is going to be a big advance to make sure that the patient gets the treatment he needs.
Thank you very much for that informative and elegant presentation, Dr. Amin.
Thank you very much.